with immediate access to potential users around the world. Bayer is illuminating the path forward, generating results from a world full of potential. We're excited for the journey ahead. Let's take the next step together. We want to meet you. Schedule a meeting to share what you're developing.
My journey continues, and I know I'm not alone. Because together, we can make a difference every day.
With immediate access to potential users around the world. Bayer is illuminating the path forward, generating results from a world full of potential. We're excited for the journey ahead. Let's take the next step together. We want to meet you. Schedule a meeting to share what you're developing.
My journey continues, and I know I'm not alone. Because together, we can make a difference every day.
Hi, good afternoon, everyone. I'm Hajime Sakuma from Japan, and it is my great pleasure to moderate Asci meets SCMR session, New Frontiers in CMR. And James Moon from Great Britain and myself will moderate the session. James, can you have a comment?
Good afternoon, and thank you for inviting me, and welcome to this excellent session. Professor Kuma and myself also represent the International Society for CMR, SCMR, based in the US, but representing our global community. And it is a great pleasure to have this joint session today.
Thank you. So, first speaker today is Masaki Ishida from Department of Radiology, University Graduate School of Medicine. He is Associate Professor of our department and now doing and managing all CMR studies at PN University. And today he will be talking about CMR mapping and its the clinical applications. So, Masaki, so please start your presentation.
Thank you for the introduction. I'm very pleased to have this opportunity today. Today, I am going to talk about CMR mapping and its clinical application. I have nothing to disclose. I would like to start with this case, which have normal LV mass and wall motion on cine-MR image, and no infarction or focal fibrosis on LGE MR image. What's your diagnosis? Actually, native T1 mapping was performed in this patient. Native T1 was substantially shortened in the entire LV myocardium in this patient, suggesting that the accumulation of lipid. This is cardiac phenotype of Fabry disease. As demonstrated in this slide, we now have got multiple quantitative parametric mapping techniques in addition to conventional CMR techniques. In this talk, I would like to demonstrate clinical usefulness of CMR mapping in several cardiac diseases. Firstly, I would focus on the native T1 and ECV. This figure comprehensively summarizes the combination of T1 and ECV in various cardiac diseases. As you may notice, there are a lot of overlap in the cardiac disease in the middle of this figure. However, Fabry disease and amyloidosis, which are the two extremes, may have the benefit in terms of the differentiation from the other diseases. This table summarizes the relation of CMR mapping and pathophysiologic mechanism in the clinical scenarios of amyloidosis, Fabry disease, native T1, and ECV provides unique information to guide clinical practice. In case of edema, due to cardiac conditions such as myocarditis, T1 and T2 mapping are useful. This slide shows a variation in normal range of native T1 when used Molly sequence. Even though the same name sequence, there are tremendous variation from report to report. Also, you have to notice that native T1 value is different between 1.5 Tesla and 3 Tesla. Therefore, it is very important to know the reference range of T1 mapping in your institution. These are the essential points described in the clinical recommendation document from JCMR. Reference range should be generated from the normal data. If full local reference range are not available for T1 and T2 mapping, quantitative results should not be reported clinically. This is important. For ECV, reference ranges from the literature using the same CMR system and same per sequence may be acceptable. Along with the expert opinion regarding clinical utility of parametric mapping, today I will focus on cardiac amyloidosis, Fabry disease, and myocarditis, and so on. There are many types in amyloidosis, but amyloidosis that affect the heart are virtually only two types, which is AL amyloidosis and ATTR amyloidosis. AL amyloidosis results from aberrant plasma cell production of monoclonal light chain. ATTR amyloidosis results from transthyretin produced by the liver. ATTR are classified into two types, familial type, that is ATTR variant, and wild type. Let me show you the cases. This is a 60-year-old gentleman having AL amyloidosis with multiple myeloma, LV hypertrophy, and zebra pattern LGE in the myocardium are observed. Global native T1 increased up to 1,400 milliseconds, and global ECV was 54%. This is a 70-year-old gentleman having wild-type ATTR amyloidosis. Similar findings that were observed in the AL amyloidosis can be detected. LV hypertrophy and diffuse LGE markedly elevated global native T1 up to 1,500 milliseconds and global ECV of 62%. CMR mapping itself cannot discriminate AL and ATTR amyloidosis. In this patient, significant uptake was observed in the LV myocardium on technetium-labeled pyrophosphate scintigraphy, indicating this is ATTR amyloidosis. Recently, it was widely recognized that bone scintigraphy with technetium-labeled pyrophosphate or DPD or MDP is useful for the diagnosis of ATTR amyloidosis. Grade 2 and 3 of bone scintigraphy finding combined with the absence of monoclonal protein findings is a strong marker for ATTR amyloidosis. This study demonstrates the diagnostic ability of T1 mapping to differentiate amyloidosis from other LVH, such as HCM. As you can see, if native T1 exceeds 1,164 milliseconds, it is cardiac amyloidosis. In the non-conclusive cases, if ECV is 70% or more, it is likely amyloidosis. It should be noted that the cutoff of native T1 is not applicable to different settings, but the result of this study is useful in clinical situation. That is, if native T1 is very high and ECV is more than 40%, the likelihood of cardiac amyloidosis is very high. Let me show you another interesting case. This patient underwent CMR for the assessment of LV hypertrophy. Patient has diffuse LVH and massive pericardial diffusion. Diffuse LGE, global native T1 was 1,400 milliseconds and ECV was 32%. What's your diagnosis? Actually, I reported that this case was a cardiac amyloidosis. Histological samples demonstrated markedly myocyte hypertrophy, myofibrillar disarray, and moderate to severe interstitial fibrosis. DFS staining and immunohistochemistry were negative for amyloid, resulting in the diagnosis of hypertrophic cardiomyopathy. In this case, T1 value was very high. but ECV elevation was intermediate, 33%. I believe that in such context, the CMR image have to be re-evaluated before concluding it is cardiac amyloidosis. Here, let me mention the prognostic utility of ECV in amyloidosis. These two studies demonstrate the usefulness of ECV in the prognostic stratification in both AL and ATTR amyloidosis, with a cutoff of 45% for AL and 58% for ATTR amyloidosis. The prognosis is significantly stratified. Moving on to the medical treatment of cardiac amyloidosis. As shown on the left, prognosis of AL amyloidosis has been significantly improved thanks to the new chemotherapy. Also, ATTR amyloidosis are treated by patisiran, which suppresses the transthyretin production, and tafamidis, which stabilizes the transthyretin, as shown on the right. Patisiran is mainly used for ATTR variant patients, and tafamidis are used for both ATTR variant and ATTR wild type. Recently, patisiran for ATTR variant patient was shown to have significant treatment effect with the evidence of ATTR amyloid regression in a proportion of ATTR variant patient receiving patisiran. We experienced several cases with ATTR wild-type amyloidosis who treated by using tafamidis. This patient was diagnosed with, as wild-type ATTR amyloidosis and treated by tafamidis for 1 year. As you see, global native T1 and ECV was substantially elevated at the baseline CMR. But after 1 year, the imaging findings, including native T1 and ECV, was not deteriorated, suggesting that tafamidis effectively stabilized the transthyretin. I will move on to the another extreme on this figure, which is Fabry disease. Fabry disease is the X-linked lysosomal disease. Due to the mutation of alpha-galactosidase A, sphingolipid accumulation occurs and causing the LV hypertrophy, inflammation, and fibrosis. As shown in this slide, typically focal fibrosis on the basal lateral wall and LV edge are observed in conventional CMR sequences. However, if the fibrosis is absent, as indicated on the left, it is difficult to suggest Fabry disease from CMR images. Native T1 is powerful tool to differentiate Fabry disease from other cardiac disease, as T1 is significantly shortened due to lipid accumulation. This slide shows the proposed stage of cardiac Fabry disease. The disease starts with the sphingolipid accumulation and proceeds to inflammatory and hypertrophy phase with the microvascular dysfunction, and finally reach fibrosis and LV functional impairment phase. Similar to the differentiation of cardiac amyloidosis, T1 mapping is useful in discrimination cardiac Fabry disease from HCM. As you can see, if native T1 is lower than 1,220 milliseconds at 3 Tesla, it is Fabry disease with a sensitivity of 97%, specificity of 93%. However, it should be noted the cutoff value cannot be simply applied to other MR scanner and different magnetic field strengths. Fabry disease is also treatable disease. Enzyme replacement therapy is mainly used to treat Fabry disease. Recent study demonstrated that enzyme replacement therapy was able to reduce the LV mass and increase the native T1, which is a treatment effect. In this patient, both LVH and T1 decrease were improved by the treatment. However, focal T2 increase, suggestive of potential inflammation, was not changed. This is our Fabry case, who was treated by enzyme replacement therapy. This patient was diagnosed as cardiac Fabry disease and treated for 1.5 years. Global native T1 and T2 global native T1 and LV mass index remained almost the same, indicating the disease was not deteriorated. And this study had a look at the treatment effect of enzyme replacement therapy depending on the disease severity of Fabry disease. That is, no fibrosis, mild fibrosis, and severe fibrosis. Importantly, exercise capacity after the treatment was shown to be deteriorated in case of Fabry disease with severe fibrosis, as shown in the bottom curve. These results emphasize the importance of early treatment. I would like to move on to myocardial edema. As you see, this table shows the usefulness of native T1 and T2 is very high to evaluate myocardial edema. This is this 70-year-old female admitted to the hospital due to severe chest pain. CMR revealed that apical ballooning, which with mural thrombus on cine and LG-MR images. Native T1 and T2 was elevated predominantly in the apical segment, suggesting the presence of edema. CMR findings are convincing to diagnose Takotsubo cardiomyopathy in this patient. Let me show you another case. This patient also admitted to the hospital due to chest pain. On T2 weighted image, diffuse high intensity is observed. Minimal spotty LGE is observed in the septum and lateral wall on LG-MR images. On the native T1 and T2 map, it is obvious that native T1 and T2 are diffusely elevated. ECB also increased in this patient. CMR diagnosis in this patient is acute myocarditis. Biopsy revealed that this is acute lymphocytic myocarditis. Okay, and this slide demonstrates that native T1 is useful to diagnose the myocardial edema. Importantly, T1 map is more accurate than T2 weighted image in diagnosing myocardial edema. Furthermore, several studies compare the T1 and T2 for the diagnosis of myocardial edema. In the diagnosis of acute MI, native T1 and T2 had comparably very high diagnostic accuracy. For Takotsubo and myocarditis, interestingly, native T1 is more accurate to diagnose this disease entity. In any way, both T1 and T2 are useful to evaluate myocardial edema. Because such background, Lake-Lewis criteria for the diagnosis of acute myocarditis was updated in 2018. Native T1 and T2 are implemented in the diagnostic criteria. Here, I would like to introduce the 2020 ESC guideline on ACS without persistent ST elevation. Minoka subsection in this document, it is clearly stated that it is recommended to perform CMR in all Minoka patients without an obvious underlying cause, that is class 1 and level B. When you experience the Minoka as a working diagnosis, that is, you see the symptom ACS, but no obstructive coronary disease on angiography, you are highly recommended to perform CMR, including T1 and T2 mapping, to differentiate true Minoka and Takotsubo, myocarditis, and other cardiomyopathy. In the last of my presentation, I would like to introduce SMINC studies. SMINC-1 study used T2 weighted image LGE in Minoka. CMR was performed 12 days after the onset. In contrast, SMINC-2 study performed native T1 ECV LGE in Minoka cases 3 days after onset. As you can see, the bar graph on your left, SMINC-2 result was much better in terms of accurate diagnosis of Minoka patients, meaning that early comprehensive CMR, including parametric mapping, improves diagnostic accuracy in patients with Minoka. In summary, CMR mapping is reliable if it is appropriately used along with the clinical context in cardiac amyloidosis, Fabry disease, and myocarditis, Takotsubo cardiomyopathy, and Minoka. I would like to emphasize that local reference range for T1, T2 mapping is mandate if you want to use CMR mapping clinically. Thank you for your attention.
Thank you very much, Dr. Ishida. And please stay with us for the discussion at the end. And to our audience, please do use the Q&A system to ask us any questions and we can try and address those with the panelists at the end. I'd like to introduce the next speaker, Dr. Dong Hwan Yang from Korea, who is the Director of CMR and Cardiovascular Imaging at the Heart Center in the University of Ulsan. And he's going to talk about an important topic of 4D flow in the heart and great vessels. Thank you. Looking forward to this talk.
Thank you, Chairman, for kind introduction. Let me start my presentation in this case of a 58-year-old gentleman who underwent Ventar's operation and replacement of the ascending aorta and total arch. Cardiovascular CT provides detailed morphology of cardiac valves, aortic grafts, and remnant descending thoracic aorta. There is plication deformity with mild luminal lettering at the proximal anastomosis site here, and distal anastomosis site between aortic arch and descending thoracic aorta was performed using elephant trunk procedure. Therefore, aortic arch flow runs through this flap-like free graft, and then what flow pattern do you predict in this post-operative aorta morphology? 4D flow MRI can provide flow pattern. You can see the flow acceleration at the proximal anastomosis site and through the elephant trunk graft. Also, there is some whirling and helical pattern of aortic flow at the just distal portion of the stenosis site in the aortic arch graft and descending thoracic aorta. On wall shear stress column map, the wall shear stress was increased along anterior curvature of the aortic graft, as you can see this figure. As you see these cases, Many researchers have said that 4D flow MRI has great potential as a suitable technique for comprehensive visualization and quantification of blood flow in the heart and great vessels. Many papers regarding clinical applications of 4D flow MRI has been published. Clinical applications of 4D flow MRI includes congenital heart disease, valvular heart disease, intracardiac flow pattern in cardiomyopathy, and great vessel disease. Therefore, many radiologists, including myself, are interested in applying 4D flow MRI to their clinical practice and their research. However, there is a big difference between expectations and reality. Then, what is the reality in 4D flow MRI for using in our clinical practice? First, imaging acquisition is quite tricky because it requires a long scan time from 10 to 20 minutes. Then second limitation is the complex data analysis process. If you want to calculate some advanced flow parameters such as Rorschach stress or turbulent kinetic energy, you may need the help of a dedicated PhD. This is a typical workflow of 4D flow MRI in my institution. After scanning of a 4D flow MRI, we need pre-processing step including baseline correction, noise masking, and image segmentation. Data analysis time depends on what parameters we need to demonstrate, typically 20 minutes to several hours. In my institution, a dedicated radiology technologist is doing this whole process with help of 2 PhDs outside hospital. Today, I would like to present 2 topics. First, some experimental studies by my team will be introduced, and then clinical application of a 4D flow MRI focused on photon circulation will be explained. I have another talk regarding the 4D flow MRI of the aorta is a section on Saturday in this Asci meeting. We have started the experimental study using 4D flow MRI since 2014. The final goal was to use 4D flow MRI in my clinical practice, at least a part of the research protocol. The experimental study's motivation was to know the following items: accuracy of 4D flow MRI, what is optimal imaging parameters, the feasibility of advanced analysis parameters such as turbulent kinetic energy, and explanation of the hemodynamic phenomenon such as helical flow and flow pattern in subvalvular pannus. Here is an example regarding the accuracy of a 4D flow MRI in terms of peak velocity. In a severe stenosis model, the computational fluid dynamics theoretical flow peak velocity should be 4 meters per second, but 2D flow MRI showed around 3 meters per second, and 4D flow MRI showed almost half, 2 meters per second. This underestimation of peak velocity is a fundamental limitation of the phase contrast MRI technique, and we should know this limitation when interpreting a 4D flow MRI in clinical practice. In post-stenotic flow, there is a recirculation zone demonstrated well on CFD here. In 4D flow MRI with a high spatial resolution, such as 1 mm isovoxel size, there is recirculation zone was shown well, but in a relatively low spatial resolution, such as 3 mm isovoxel, the recirculation zone did not delineate it well. To validate advanced hemodynamic parameters from 4D flow MRI, such as turbulent kinetic energy, we applied particle image velocimetry as the reference standard. You can see the flow patterns, which is demonstrated by tiny particles in the flow phantom. In this validation study, MRI measurement of turbulent kinetic energy showed a very nice agreement with the reference standard particle image velocimetry. This is a recent validation study of turbulent kinetic energy using a newly developed sequence more suitable for the measurement of TKE by our group. We explained some interesting hemodynamic phenomena using a body flow MRI. This study suggested that the helical flow may result from aortic flow angle, not by valve morphology itself. This is an experimental study to show the relationship of flow distribution error and spatial resolution in body flow MRI. The result of this study helped set up our image acquisition protocol in my institution. Currently, in Asci Medical Center, we are doing body flow MRI in the following scenarios as a research protocol. Fontan operation, aortic aneurysm, ascending aorta flow evaluation in patient with aortic regurgitation before and after valve surgery. We use 3 Tesla MRI machine, mainly Philips. In-house code of MATLAB and ReconFrame software were used for post-processing image. For visualization, we use either CVI or GTFlow. Among clinical applications, I would like to focus on Fontan pathway evaluation today. We are doing body flow MRI routinely after completing Fontan operation around 3 years old as a baseline study. Then let's review what the Fontan operation is and why body flow MRI could be promising for evaluating Fontan circulation. As we all know, cardiology is an academic field dealing with the flow. The primary goal of the cardiovascular system is to drive blood flow through the body. The ventricle must provide the flowing blood with enough energy to overcome the unavoidable friction loss of energy. Energy-consuming blood flow, such as flow separation or helical flow caused by abnormal geometry, provide an increasing workload to the ventricles, which may ultimately result in heart failure. The degree of energy loss and its hemodynamic impact is conventionally assessed with indirect and global parameters such as vessel size, pressure gradient, or effective orifice area estimated by velocity-based imaging on echocardiography. This is the first report in 1971 by Francis Fontan about the surgical repair of tricuspid atresia. In tricuspid atresia, right ventricle is very dysplastic, so pulmonary circulation should be restored. Dr. Francis Fontan simply connected SVC to right pulmonary artery and right atrial appendage to left pulmonary artery. This is the first Fontan operation. Fontan operation is a definite palliation procedure for patients with complex congenital heart disease who are not suitable for biventricular repair. Atriopulmonary connection in the left panel was the initial form of the Fontan operation. Now, almost all centers perform cardiopulmonary connection using the extracardiac conduit. Then, why cardiopulmonary connection instead of atriopulmonary? There was interesting hemodynamic evidence for changing the surgical method. This is a landmark study in 1988 that proves the superiority of total cardiopulmonary connections hemodynamics. They designed in vitro circuit for steady flow through the valveless chamber right atrium. This is flow volume and pressure loss curve in various geometry of the flow circuit. A cavity with offset here mimicking right atrium was equivalent to 50% stenosis. That means the right atrium to pulmonary connection could be inefficient hemodynamically as compared to the tubular connection. This study was the scientific background for performing cardiopulmonary connection. Take a look at this author named Philip Kellner. 12 years later, in 2000, Dr. Killer published another landmark study in the journal Nature. He showed asymmetrical intracardiac flow using 40 flow MRI. This is the right atrial flow. Blood entering from SVC and IVC contributes to the forward rotation of the blood in the expanding chamber at systole. Blood enters from the pulmonary veins on each side are redirected round toward the mitral valve. This is very nice but quite difficult article dealing energetics of blood flow in the Fontan circulation. Let's dive a little deeper. There are two critical tasks of a Fontan circuit. It should be as energy efficient as possible, and it has to distribute hepatic blood flow to both lungs because a lack of the hepatic factor is associated with the formation of pulmonary AV malformation. The surgical method of TCPC, total cardiopulmonary connection, has been evolved to minimizing energy loss and prevent the preferential flow to a unilateral pulmonary artery from IVC. Let me introduce previous works regarding 40 flow or CFD application for Fontan circulation. Of surprise, there are a lot of previous articles with a long history from 2003. Most researchers applied computational fluid dynamics, not body flow MRI, and there was a low longitudinal follow-up study to find prognostic hemodynamic factors. Dr. Asci Yoganathan from Georgia Tech is one of the pioneers in this field. His group did a lot of research using both 40 flow MRI and CFD in patients with Fontan circulation. This study tried to quantify average hemodynamic metrics as reference for future investigation from 100 patients with Fontan circulation. They described the relationship between hemodynamic metrics and other clinical parameters such as body surface area and pulmonary artery size. Also, they found a negative correlation between indexed power loss in TCPC and patients' exercise capacity. That means if we measure energy efficiency of Fontan circulation using body flow MRI, we might predict a patient exercise capacity or a patient prognosis. Until now, we did 40 flow MRI about 50 patients who underwent Fontan operation in my institution. All MRI was performed immediately after Fontan operation, typically 3 to 4 years old, as a baseline study to see longitudinal follow-up data. This is the time-reserved MR angiography. We can see the extracardiac conduit here and mild preferential flow to the left lung from IVC. On 40 flow MRI, we can calculate hepatic flow distribution in this patient. 97.1% of hepatic flow went to the left pulmonary artery. That means this patient has a risk of atrial pulmonary malformation in the right lung. We also calculate viscous dissipation as an energy loss parameter. You can see how viscous dissipation in the right pulmonary artery orifice. Second case showed a balanced flow to right pulmonary artery and left pulmonary artery. There was no offset in the TCPC. Overall, viscous dissipation was relatively low. Case 3 showed mild left offset but severe preferential flow to the left pulmonary artery, 93% to the left pulmonary artery from IVC. This last case also showed mild left offset but relatively balanced flow, and fraction of left pulmonary artery from IVC is 69%. To be a decision-making tool after Fontan operation, further studies are warranted. First, the minimum amount of hepatic blood flow from preventing pulmonary AVM should be determined. Second, studies regarding Fontan circuit modification or virtual surgery for minimum energy loss and minimum hepatic flow are needed. And finally, we need to elucidate energy loss parameters predicting clinical outcomes. And this is an excellent study showing the relationship between CMR-derived parameters and liver fibrosis after Fontan operation. Increased resistance in the Fontan circuit showed a positive correlation with liver fibrosis. Still, we have a lot of hurdles for the clinical application of a 40-flow MRI. A dedicated software module fits into a specific clinical scenario, such as Fontan module could be a solution. I hope my group could contribute to setting up this solution. Using 40-flow MRI, we can see the flow pattern, but we are not sure which flow pattern is the pathology that requires treatment. This is the main problem we face after we apply 40-flow MRI in our clinical practice. To solve this problem, we need a reference standard for a healthy volunteer, covering various ages and advanced hemodynamic parameters. This is an ongoing volunteer study in my institution. We are gathering normal hemodynamic parameters using 40-flow MRI from volunteers who conform to normal using echocardiography. Ladies and gentlemen, this is my conclusion. 40-flow MRI has excellent potential, but lots of limitations still exist. Further studies are needed to prove clinical additive value of 40-flow MRI. Thank you for your kind attention.
Thank you so much. Great talk, especially focusing on the Fontan procedure. So, because of the time limitation, we will have a discussion at the end of the session. And I will like to introduce Professor James Boone. He is a professor of cardiology, Barts Heart Center. And he is very famous for the as a founder of an international T1 mapping working group and past president of British Society of CMR. And he also has, in addition to the nearly 400 publications, he has a citation of more than 32,000 and H index of 76. That's amazing. Okay, so he'll be talking about quantitative CMO perfusion mapping. Yes, please, James.
Thank you, Hajime. Would you tell me if you can see my screen when it comes up now? Where is my screen? Can you see my screen yet? Can you see the slides?
Yes, thank you.
Great. So I'm going to talk about quantitative myocardial perfusion, and we call that perfusion mapping. And this is work that has been developed in collaboration with Barts Heart Center and a network of other centers, and Professor Peter Kalman at NIH with FreeTube. I've got no conflicts of interest, and it's just really nice to come back to CMR because for the last 18 months we've been doing COVID research in my hospital led by imaging doctors, and you can see some of the papers there, and I've linked some of the with QR codes if you're interested. So what we want to do is determine who has coronary artery disease, or specifically obstructive coronary artery disease, and we want to do that without doing invasive angiography. There are a number of different ways of doing that because we can exploit the ischemic cascade. And as you know, you need to do this during stress, and that can be exercise, inotropes, or vasodilators. Perfusion CMR is non-invasive. It has an advantage of no ionizing radiation. It's a functional test rather than an anatomical test like CT. We use adenosine typically, although you can also use regadenoson or dipyrimidol. So that's not an inotrope, although you get some reflex tachycardia. And we are measuring blood flow and its difference between stress and rest to get the myocardial perfusion reserve and the peak myocardial blood flow. So this has been around for more than 15 years. And you see a typical study done around the world here with rest flow at the bottom and stress flow at the top. And we are tracking a bolus of tracer, here gadolinium DTPA, as it goes into the right ventricle, the left ventricle, and then through the coronaries into the myocardium. At stress, a flow-limiting stenosis will reduce the amount of contrast taken up by the myocardium passively, and you see a perfusion defect. Here, territorial in the mid to apical infraseptum, looking like probably LAD actually, stenosis. But that is subjective, and some of the cases can be quite difficult to judge with some inter-observer variability. If we could fully quantitate this, there would be potentially more accuracy and precision. It could be faster. We could get around some of the problems that we've had in ischemia testing, which is balanced ischemia, and maybe see not just the most obvious defects, but the smaller defects, expanding from 1 to 2 to 3 vessel disease, because sometimes additional vessels are missed. When you have a new technique like this, there's always potential for prognostic information and new insights and new uses, for example, in microvascular disease, an area of real importance. Now, to do that, however, there are some technical challenges, and I outline them there, and I'm going to show you what has been done, and this has all been done on the scanners, initially with Siemens scanner, allowing the generation of these maps inline, a little bit like PET, but there have been some significant challenges to solve going along to delivering this. When we give that bolus, we are measuring the arterial input function of the blood pool, and then we have to measure the myocardium and deconvolute these to understand what's happening in the model, in the tissue. And we have to have a model for that, and the one used here is the BTEC model, blood tissue exchange model. And there is lots of maths here and lots of optimization, and this has been done brilliantly by Peter Kelman and team. And the results are actually the solutions of 4 variables in partial differential equations, and the one we're interested in is blood flow, and each pixel represents the flow in the myocardium as the product in mils per gram per minute. And about 20 seconds after having done the scan, these images come up on your scan. The analysis chain is here. It depends on excellent image acquisition, motion correction, significant corrections, and then the maps. But these are additional maps to the conventional images, so you can use your clinical judgment on the conventional images as well. So what you get is pictures like this, and stress is on the top and rest is on the bottom. And you can see in the rest that the flow, here represented as blue, is around 1 mil per gram per minute. But in this young person, the flow goes up to more like 3.5 mils per gram per minute. That is 3.5 times higher fold flow with adenosine. In the patient on the right, whilst there are some areas with increased flow, there are several areas where the flow has stayed more blue. This is at least 2 vessel disease. It's incredibly easy to see, and we are now using this in routine clinical practice at Barts, and we do about 5,000 of these scans a year. So the perfusion mapping does a number of things. The basic stress sequence is better. The motion correction is better. You can see the defect much better once you've got nice motion correction if you compare the two. The map is full quantification with no user input. We don't need to do anything. It's very fast. And we are now exploiting AI inline on the scanners in routine clinical care. So these contours here are drawn by the scanner. You can actually see that the AI has captured the slight tremor of the person who trained the system. And those segments are outputted with blood flow maps and myocardial perfusion reserve maps automatically by the scanner. We have a whole bunch of additional outputs, so we can see the respiratory rate from the motion correction, the pulmonary transit time, because you can get the RV input flow and then the dilution and the lower peak to the LV input flow. And that pulmonary transit time we now know is prognostic. We can see all the aspects of the stress and then the maps, both segmentally and subsegmentally with endo and epicard. So you've seen some of it, and what does it look like? So here's an example of stress versus rest, and you can see the anterior wall is blue, and so is the mid to apical lateral wall. So that's 2 vessel disease. Very easy, nice exemplar case. But if you want to adopt a test, there is a process to go through. And this is an old framework that I created and used for T1 mapping, for example. And it is increasingly difficult to go down this. So I've shown you so far the technical development of a test. But what we really want to get down to is the proof that the test changes clinical outcome and can guide therapy. And you can see also that there are a number of things to be done, like reference ranges, standardization, use in trials, for example, as you go along this process. And we, as a group working across around 14 hospitals in a sort of loosely coordinated network, we have done a lot of this work. This slide is actually about a year old, and we'd had done 15,000 scans by then, and 9 fellows have been involved. And you could see that we had started with the descriptions, and then what normal is, and then moving on to how well you can stress people, microvascular disease, quantification in different specific circumstances, like here, hypertrophic cardiomyopathy, and then prognostic studies. This study was published towards the end of last year by my group. We looked at around 1,000 subjects, and because the AI segmentation allowed this to be done efficiently, we could measure global and segmental blood flow and show that actual perfusion quantification predicted outcome. And that was independent on whether you could see a regional perfusion defect at all. Quite an important milestone for the technique. So we've been talking about macrovascular disease mainly, but what about microvascular disease? The heart is comprised of both myocytes and the capillaries, 2 specialist cells, one for contraction and one to supply blood to the myocardium. And they grow together in cardiomorphogenesis in the fetus and are intimately linked. And what we find by looking at our project cohort is that maximal hyperemia is not the same for everyone. And this is an equation, it's not published yet, so I'm showing you some unpublished data, that you can think of the stress flow as around 2.7 mils per gram per minute, but it goes down a bit with age, it goes down with LVH, it goes down quite a lot with diabetes, and then there are some other outliers like beta blockers seem to reduce it. And so if you see a very orange vasodilator, that's good for a young person, but an older person with some of these things may not have that degree of hyperemia. So we've got to think about a reference range that changes in different scenarios. Furthermore, whilst we think about macrovascular disease, there is clearly other things going on. So this is a hypertrophic cardiomyopathy patient. You can see that they have apical hypertrophy and some basal anteroseptal. So this is an apical predominant. The rest flow is normal, but the stress flow, whilst there is some reduction in the septum, is very profoundly reduced at the apex. And I'm showing you some long axis views as well. In fact, we've now seen that the flow during vasodilator stress in the apex can be below that you find in rest, either because of persistent contraction, reducing blood flow, or maybe steal. We're not quite sure why, but this is a real phenomenon now. And these changes are quite profound. They can also occur before the onset of hypertrophy. So I'm sorry for the messy images, but this is the rest on the right-hand side and the stress on the left. And you can see that this patient, now the imaging is slightly systolic, but this patient has no LVH and no late gadolinium enhancement, but they do carry a pathogenic gene. And you are seeing focal perfusion defects at a place where we know that scar often forms, and a global reduction in perfusion before the onset of detectable hypertrophy. And we've now just published that 1 in 5 subjects with a gene and no LVH have this. It appears that commonly perfusion defects precede hypertrophy, raising questions about exactly how and what hypertrophic cardiomyopathy is in its sequencing, from the gene mutation through to the clinical phenotype that we see and know. The techniques I'm talking about here represent a new generation of sequences, a chain of analysis being done on the scanner with multiple steps involving artificial intelligence, initially for feature extraction to identify with absolute certainty the blood pool, and segmentation. And we're using this now to start to suggest diagnoses and confidence in images as well. Practically, when you get a new technique, there's an adoption process, and it requires a lot more understanding than just the technical. And we've been going through this at Bart's Heart Center and others, and are now routinely using this in clinical practice. And part of that involves a lot about quality control. This is a new slide. I'm not going to go into the details, but it's just how you look at the images and work out whether or not you can trust the maps, and to unpick it if there are any problems, for example. And when they're orange like that, I have complete confidence, for example, that the scan is normal without having to look at the source images. So to summarize, myocardial perfusion quantification has been a goal for a long time. And here in perfusion mapping, thanks to NIH and a network of clinical centers, there's been an inline solution that is highly usable. It's obviously a functional technique and moves away from visual interpretation to direct quantification, exploiting computational power and AI. And it really is transforming how we are doing things. It's a useful add-on, but I think we're going to see, especially in the domain of microvascular disease and cardiomyopathy, major insights. So, and this is in the product pipeline for Siemens, but is only currently available in about 20 centers or 30 centers around the world. But hopefully soon it will be more widely available. Thank you very much. Just before I finish, I would like to remind you of a hybrid meeting coming up for SCMR. Here we partner with Asci today, but in February in Fort Lauderdale, fingers crossed, there will be our first partially face-to-face meeting, and we look forward to seeing some of you there. Thank you.
Thank you, Professor Moon. At Mi University, Masaki started quantitative perfusion CMR in daily cases, in a routine basis. And we found that quantitative perfusion map is great. I think your presentation is very exciting, especially the abnormal flow reserve in a patient without LV hypertrophy in HCM carrier. So that's very interesting. And okay, so Thank you so much.
Thank you. Thank you. I'm going to introduce the next speaker. I'd like to introduce Professor Nicole Sevelich from the US Radiology Department in the University of Michigan. And she's another expert in MRI and going to talk about a really interesting area of CMR fingerprinting and clinical applications. Once again, do please ask some questions and then we can have a discussion at the end and hopefully help answer any of the questions you have. Thank you, and I look forward to your talk.
Hello, everyone. My name is Nicole Seiberlich, and I'm an associate professor in the Department of Radiology at the University of Michigan and co-director for the Michigan Institute for Imaging Technology and Translation. And before I get started, I just want to say what a delight it is to be invited here to speak to all of you today. And I'll be talking about CMR fingerprinting and its clinical applications. Before I get going, I should report that my lab receives research support from Siemens Healthineers, and I also receive royalties from Siemens Healthineers for magnetic resonance fingerprinting. So typically, when we collect cardiac MRI images, we collect images which are qualitative in the sense that the intensities of the pixels don't reflect any one particular tissue property. Of course, the contrast that we get is a result of a combination of many different tissue properties and the MRI pulse sequence that we use to collect the data, but we're not really making a quantitative measurement of any one tissue property here. Of course, it is possible to generate quantitative maps of tissue properties like this T1 map that I'm showing on the right-hand side, and there might be a lot of benefits to doing that. So in the ideal world of quantitative MRI, we could imagine measuring a tissue property like T1, and we would be able to see a clear cutoff between measurements in healthy subjects and measurements in patients who have a particular disease. And so if we'd make a new measurement of a patient, we'd be able to clearly state whether their myocardium was healthy or diseased based on the measurement that we made. Of course, T1 is just one of these tissue properties that we could measure with MRI. There are many others, including T2, extracellular volume fraction, T2 star, fat fraction, the list goes on and on. And we know how many of these tissue properties change in different disease states. And so it's possible to believe that if we measure enough of these tissue properties, we might be able to distinguish healthy from diseased tissues. And the more tissue properties we measure, the clearer discrimination we may get between these two different populations. In fact, we can imagine measuring multiple tissue properties, looking at their values, and clearly being able to distinguish healthy subjects, here shown in black, from patients with one disease, here in magenta, and maybe a different pathology, here shown in red. However, we face the problem that there are many confounding factors when it comes to mapping these tissue properties in the heart. These are due to how we collect the data, system imperfections in our MRI scanner, the presence of other properties in addition to T1 or T2, like fat, that we're not necessarily measuring, and then, of course, physiological variations. So I'm just going to give you an example of how we perform T1 mapping with a conventional technique known as MOLI to explain where these confounding factors might occur. So we can see here the pulse sequence. So here's the patient's EKG. We start off with a 180-degree inversion pulse, and this sensitizes our magnetization to T1, the value that we'd like to map. And then we see that data collection here in these phases in end diastole. And what we're trying to do is follow the signal recovery curve. This recovery is due to T1. And we're collecting data in various heartbeats to follow the signal time course. So ideally, what we're going to get is the signal, which is a function of time. That's what I'm showing here in the spread curve. And it's an exponential recovery where the recovery time depends on the T1 value of our tissue. So if we measure the signal at multiple times, we should be able to recover the T1 value for the underlying tissue in our pixel. So this is an ideal case where we've made a perfect measurement and everything is great, and we'll get a T1 value of about 1,000 milliseconds, or exactly 1,000 milliseconds, because that's how I did the simulation. However, if we run up against some system imperfections, which often happens, we can see that we have some errors in our relaxation curve. These can occur especially at the very beginning of our curve, where they're particularly problematic when it comes to our measurement. And so if we try to use the same equation or a slightly altered equation to do this mapping, we'll end up with the T1 value that is incorrect. It's only 944 milliseconds in this case. If we add noise to our measurement, which we'll always have, and we try to map the T1 value, then we get an even lower value. This is now less than 900 milliseconds using just slightly altered data. And this is a pretty realistic scenario. We also remember that we're collecting our data at specific time points. So these depend on the patient's heart rate, and we can get a little bit of jitter in this data. So that can cause some errors as well. And often we choose to leave out these last couple of data points in the part of the curve where the signal isn't changing so much. But if we leave out too much of this data, we'll again end up with an erroneous T1 value. So you can see that there's lots of ways that we could end up with a T1 value that isn't correct, even when we're doing our best to collect this data. And this is a problem which is commonly known, especially for T1 mapping. So this is a really nice paper by Bullock where he's looking at the different pathologies which can be examined using T1 mapping. But in this paper, it is stated that T1 mapping is an evolving field and numerous factors currently preclude a standardization, which is exactly the problem that we were looking at on the previous slide. This is a really lovely white paper by the eminent Dr. James Moon, who is involved in this session as well. And in this paper, they state that significant biases in T1 measurement may depend on the specific method and imaging protocol. So it's important to establish site normative values for that particular setup. And this makes it very difficult to come up with a standardized T1 map. This is highlighted on this slide here, which was a study that was done by Peter Kelman. So here, he's first showing in a healthy subject the T1 maps that he gets when using the Molly technique. We have a mean value at 1.5 T of about 1,017 milliseconds in this ROI. Using a slightly different version of Molly, where we've changed the acquisition approach, we do have a much lower T1 value, exactly like in the simulation that I was showing before. And if we move to a completely different pulse sequence, which is often used to also collect T1 maps, known as Sasha, it's just a different acquisition structure. But here you can see that we're having a much different value for T1. This is over 1,200 milliseconds. And if we change how we fit our recovery curve, we might get yet another T1 value. And you can automatically see how this would be problematic because we have a large variety in our measurements just in the same healthy subject. Again, this will lead to the need to establish these site normative values. So in site number 1, we might have a certain range which we'd expect for healthy subjects, but these might be different in different sites because of how we're collecting our data, how we do the post-processing, and again, different MRI systems may have different imperfections. So these inconsistencies in our measurements may lead us to question the value of measuring even T1, let alone some of these other quantitative tissue properties that we may be able to access with MRI, but we don't really see the point if we're going to have all this variation. So unlike the dream we had before, where we could clearly distinguish healthy myocardial tissue from pathology, we may have a situation more like this, where if we measure now a new patient, we can't really tell objectively, just using one particular tissue property, what might be going on here. All right, so this brings us to magnetic resonance fingerprinting. So MRF is an approach for mapping multiple tissue properties using MRI simultaneously. So here, instead of using this accepted signal model, which we try to squeeze our data into, we're going to model the signals as we collect them and match these modeled signals to physics simulations in order to extract T1 and T2 maps. And what we're hoping to do with fingerprinting is to generate reproducible and efficient measurements of tissue properties like T1 and T2, but not only T1 and T2, simultaneously. Okay, so unlike the traditional tissue property mapping techniques, which I talked about explicit with T1, but they're actually quite similar for other tissue properties, fingerprinting is going to use signals which are very, very different. So here, instead of having exponential recovery curves, which might easily appear very similar depending on imperfections that we have in our setup, these MRF signals are designed to look very different so that we can separate tissues with different properties from one another. This is the pulse sequence that we're currently using for cardiac fingerprinting. So you can see that we start with an inversion pulse to sensitize our signal to T1. We are collecting our data in the scan window here, again in diastole during a breath hold. And then over the course of 5 heartbeats, we change the flip angle pattern from a maximum of 12 degrees to a maximum of 25 degrees. We also are playing out T2 preparation pulses in some of these heartbeats in order to sensitize our signal further to T2. So during our acquisition block, we collect highly accelerated spiral data. We'll see that if we take just one of these spirals, which looks something like this, and we turn this data into an image, these are what our images look like if we would look through this acquisition block. So we see that because of the high degree of undersampling, we have a lot of aliasing, which really looks like noise. We can't really make out anything in our images. However, we know the parameters that we played out in our pulse sequence. And we also know the ranges of T1 and T2 that we would expect to see in our tissue. And so we can use these together in a big physics simulation known as a block equation simulation to calculate a dictionary of possible signals that we could see in our experiment. So you can see that if we have a tissue with a T1 of 500 milliseconds and a T2 of 50 milliseconds, the signal over time should follow this dark curve here. And different tissues with different combinations of tissue properties will have different signals over time. So now the trick is to match signals in time in these highly accelerated images to this dictionary here. So if we look at 1 pixel over time, we'll see that it looks very noisy because of these aliasing artifacts, but we can still make out some structure there due to the T1 and T2 in that underlying tissue. And we can simply take this signal magnitude and match it to our dictionary to find the dictionary entry that matches the best. And if we do this over all of the pixels in our image, we'll end up with maps in the heart in this case, which look like this. So here we have T1, T2 in the center, and proton density on the right-hand side. So the acquisitions that I'll be talking about primarily are collected with a spatial resolution of 1.6 by 1.6 by 8, with a total scan time of 15 or 16 heartbeats. We collect this data also in a breath hold. This is a very similar scan time to the MOLY acquisition, in which we can collect T1 alone. Okay, so why do we think that using fingerprinting is going to help us when it comes to mapping cardiac tissue? Well, the first thing that we talked about is how the pulse sequence design is going to be specifically selected so that we can pull out any system imperfections. We can essentially model those as part of our physics modeling and remove the confounding effects of these errors from our reconstructed tissue property maps. And so these are going to be mostly pushed by the wayside. Due to the fact that we're mapping multiple tissue properties simultaneously, these tissue properties don't negatively impact one another anymore because we're simply mapping them all. And so this makes it a little bit easier to avoid these confounding factors. We are left with physiological variations, but in addition, because we're modeling the subject's heart rate, we don't have to worry about that. And the fact that we now are really looking at variations due to age and gender, it may be easier once we've reduced some of these confounding factors to get a better idea of what's going on in that underlying physiology for healthy subjects. So this may make it easier not only to collect large data sets where we can better understand what's going on with the hearts of our healthy subjects, but also to pool our data to get a better idea of what we can assess using these tissue properties in different cardiac diseases. Okay, so I'm going to show you a couple of maps that we've collected first in healthy subjects. So on the left-hand side, you see the fingerprinting T1 map. On the right-hand side is the conventional T1 map that we've collected using MOLY. And of course, while we collect fingerprinting T1 maps, we'll also get a fingerprinting T2 map, which I'm showing on the left-hand side, and comparing to the conventional T2 map, which was collected using a T2 prepared balanced SSFP sequence on the right-hand side. So you can see that our tissue properties look very similar. In fact, we've scanned nearly 60 healthy subjects on our 1.5 Tesla Siemens era. And we see that we're getting very similar values between cardiac fingerprinting and MOLY. You can see that on this plot on the left-hand side. And in fact, our test-retest results are a little bit better with fingerprinting than they were with MOLY. On the right-hand side, you can see a test-retest fingerprinting, test-retest study for T2. Our fingerprinting values are significantly lower than those that were measured with balanced SSFP, but we're getting a very similar reproducibility between these two. We've also done a forced choice image quality assessment. These images were assessed by 2 experienced cardiologists, and we asked them to say which map they preferred, either the conventionally collected map or the fingerprinting map. And as you can see, fingerprinting is shown here in red, and it was preferred by far more than the conventional mapping techniques, and these differences were all statistically significant. We have started to use our fingerprinting techniques also to assess patients. This is an example of a patient with a myocardial infarction that was scanned at University Hospital's Cleveland Medical Center. So the fingerprinting maps are shown at the top and the conventional maps are shown at the bottom. So you can see clearly that the infarct is visualized on both of these maps with elevated T1 values and T2 values. And we can also see this area here of lower T1 value in the post-contrast T1 maps as well. We're also collecting data in patients with hypertrophic cardiomyopathy. This work is being done by Yuchi Liu and Sanjay Rajagopalan, who is at UHCMC as well. So the fingerprinting maps are again shown at the top, and the conventional maps shown at the bottom. And again, our fingerprinting maps look very nice and compared to our conventional maps. Here you can see this is the fingerprinting T2 map, which we collected in diastole. It's a little bit of a cleaner diastole than what we saw in the conventional T2 maps because the subject's heart rate was very high. We're also collecting data in amyloid patients. This is in collaboration with Brendan Eck and Debbie Kwan at the Cleveland Clinic. So our healthy subject is shown on the left-hand side here. The amyloid patient is on the right-hand side. We can see that both T1 and T2 were elevated quite significantly compared to the healthy subject. This can be very nicely assessed using fingerprinting. So far, I've shown you that fingerprinting can map T1 and T2, but we can already do that clinically. So what else might fingerprinting be able to do that will further enhance its value? So one thing that we're quite interested in is using the tissue property maps that we've collected to generate synthetic images. So if we start with these tissue property maps, we can convert them into T1 and proton density weighted images just by using the signal equation along with our maps. We can also generate T2 weighted images and even inversion recovery images. And we believe that this technique will also allow us to better examine scar tissue. This is work in progress right now. We can, of course, measure other tissue properties in addition to T1 and T2 using the fingerprinting framework. This is work that was done by Gaston Cruz at King's College London. And so here in the heart, they have mapped not only T1 and T2, but also T2 star and proton density fat fraction using fingerprinting. So you can see these maps here at the top in comparison to the reference images, which are shown at the bottom. And again, all 4 of these maps can be collected simultaneously using fingerprinting. They've also done a preliminary investigation in a clinical setting. So here again, our fingerprinting pre-contrast or native acquisitions. These are the post-contrast results. You can see that they look quite nice. And this data can be used to also generate ECV maps. Another parameter that might be interesting to map is T1 row, which could be used potentially in place of a contrast agent injection. This is still very preliminary, but it's a really exciting parameter to look at. So here we see, again, the T1 map, T2 map, and T1 row map collected simultaneously using fingerprinting, and the conventional maps are shown at top. So the image quality of the fingerprinting maps is in my mind, far superior to the conventional acquisitions. Jesse Hamilton at the University of Michigan is working on combining T1 and T2 mapping with fingerprinting along with Cine acquisitions. So our goal here is to replace Cine imaging completely with a fingerprinting-based approach where we'll get not only measurements of function like ejection fraction and the ability to examine the cardiac motion, but also T1 and T2 maps at the same time. So again, this is something that we're quite excited about, looking at motion in addition to mapping. And eventually we may be able to really collect everything all at once. This is some really exciting work, again, done by René Bottner, Claudia Prieto, and Gaston Cruz at KCL, where they are performing whole heart 3D fingerprinting in free breathing. So you can see these maps of T1 on the left-hand side and T2 on the right-hand side collected just during free breathing, which may make it a lot easier for the patient to undergo an exam like this. Okay, so I hope I've given you a little bit of taste of magnetic resonance fingerprinting and given you some insight into why we believe that it may be part of the future of CMR, where we can generate quantitative maps in an efficient manner in a way that's very easy for the patient and hopefully the people running the scans. It may be possible to collect a variety of maps of different tissue properties, which could be used quantitatively. We may still be able to add to some of these pieces of quantitative information, and even collect more conventional quantitative metrics like ejection fraction, mass, and strain, all in a single fingerprinting experiment. We would love this to be an acquisition that gives us 3D isotropic resolution in a free breathing, ungated manner, maybe even avoiding the use of contrast agent, and to have it be automated both in terms of how we do our acquisition and even with some of the post-processing and the reading of these numbers. So with that, I would like to thank my team who has been instrumental in this work, especially Jesse Hamilton and Rachel Liu. And again, thank you all for your attention.
Okay. So, great presentation, and we'd like to start our discussion. And for Professor Moon, there are several questions for you that was answered by the question and answer. But for the audience or listening to the webinar, I would like to repeat the question. So the pulse sequence you are using for the absolute quantification MRI is currently a prototype.
Thank you, Jimmy. It is a sequence that was a prototype, and we were running it with additional hardware to make it faster and to curate the raw data. But it has now been made into a work in progress package, and that is scheduled for release by one of the manufacturers, Siemens, but I don't know when. Currently, I think it's being used in about 30 centers, but really, I think it's been very well tested and ready for a broader release.
So, do you currently use dual bolus or dual sequence?
So, the question is about how we do the absolute quantification. And in around about 2003, we used to give a very small dose of contrast to measure how quickly the arterial input function worked. So you'd have to do a small dose to avoid this T2 star clipping and T1 clipping, and then do the main injection, and then have to do a lot of processing. This is the dual sequence approach, where when you read out 3 slices, there's a low-res image taken first for the AIF, and that is partially artificial intelligence analyzed. So this is a dual sequence approach.
Okay, Masaki, Dr. Ishida. So, what is the situation? Can you explain the situation in Mie University?
Okay, we are using a Philips scanner, and we also use dual sequence techniques for the quantity perfusion mapping. And I understand the sequence is still work in progress. So I don't know when it is distributed to the clinical site. And that is our situation.
So as Professor Moon mentioned, the dose of contrast can be increased when dual sequence is used. I found that the contrast to noise of the image is much improved by using a dual sequence instead of the dual bolus approach. Do you think so, Masaki?
Yes, I think so. Dual sequence has a advantage which allows us to use the higher concentration of the gadolinium.
So what about perfusion quantification in Korea in Assam Medical Center? Sorry. Oh, sorry. That's. Do you have any comment about? Oh, okay. Okay, so yeah, I'm very happy to know that absolute perfusion quantification may be available by the multiple vendors in a relatively near future, I hope. Okay. Okay. Thank you.
So if I could ask some questions. Dr. Ishida, I really liked your pictures, especially the ones from your acute patients. Really nice image quality. It was a pleasure to look at. One of the things you mentioned was Minoka. So myocardial injury with without a coronary obstruction scenario. How it's one of the areas where MRI adds real value. How much do you use that? I mean, how many of your patients in your center are getting cardiac MR?
Okay, thank you for your question. Actually, in our institution, we have very rare cases with Minoka. Before doing the cardiac MRI, during the cardiology told us several weeks ago that during the cardiac procedure, they can somewhat predict the cause of the Minoka. So usually before going to the CMR, before doing the CMR, the diagnosis is done. But I think in that case, if you use the CMR test, the diagnosis is more convincing. So personally, I should do CMR in all Minoka cases. But we don't have many cases so far, so we are collecting that kind of cases.
Go on.
Oh, yeah, one of the background is that in Japan, that Asian countries, coronary spasm is quite common. So that's maybe the difference between the Asian countries and European countries. So the test for the spasm is frequently done during the cardiac catheterization.
Okay.
Yeah.
So with acetylcholine or something?
Yes.
A challenge test. Okay.
Yes. That's pretty common. Yeah.
We are finding in London, and we do a lot of cardiac MR. It's our primary. It's a really important diagnostic test. That our service is becoming much more inpatient orientated. So we do about 25 scans a day, but about 5 on average will be inpatients. And a lot of those will be in acute scenarios like post-VF arrest or VT storms, or people who've had unexplained troponin elevation, or where the explanation is not completely satisfactory. And there's a really good yield from that. So we're having a lot of myocarditis, flush occlusions, tachycardia, all those things. If I could ask Professor Dong Huan Yang, I loved your, those pictures from 1988 from Philip Kilner of the 3D flow and the asymmetry, and just the way you're thinking about preservation of energy, and with such a clinical utility in Fontan. Do you think we could be using 4D flow routinely in clinical practice? Are you using it routinely in your congenital heart disease practice?
First, sorry for technical difficulty. My microphone was muted. That's why I could not respond Dr. Sakuma's question. And for answer from Professor Moon, first, we are applying 40 flow MRI in patient with congenital heart disease, complex congenital heart disease, after completing Fontan operation. But we don't have clear answer, or we don't have clear perspective. But we, as I show my slide, 40 flow MRI could provide us to a flow distribution. That is very unique role of 40 flow MRI, and we speculate that flow distribution information could provide some prognostic information regarding pulmonary development of pulmonary AV malformation. That's why we are doing 40 flow MRI. But there is big technical problem. The most important problem is long scan time. So if we want to apply 40 flow MRI in relatively big patient or adult patient, it requires quite a long time of scanning, such as 20 to 30 minutes. That is the most important problem to solve.
Well, I'm optimistic that will improve over time. Hajime, I think we are being asked to wrap up. Would you close the session? It's been wonderful. Thank you very much.
Yes, I'm so excited to participate in this really wonderful session. Asci meets ACMR. And I think the participants from Asci side can obtain very decent information about the perfusion, CMR, and also the fingerprinting. That's a very advanced area. And I also impressed with the use of 40 flow for the specific patient of Fontan. That is a very useful application. And thank you for speakers and organizers for giving us this wonderful opportunity. Thank you so much.
Thank you.
Thank you.
Thank you.
Thank you.
Bye.
Bye.
with immediate access to potential users around the world. Bayer is illuminating the path forward, generating results from a world full of potential. We're excited for the journey ahead. Let's take the next step together. We want to meet you. Schedule a meeting to share what you're developing.
My journey continues, and I know I'm not alone. Because together we can make a difference every day.